And there we go. I was going to say, John Henry, if I had a camera, turn that on, but I think we're ready to move forward.
Give me one moment here. I apologize.
That's fine.
All right, so thank you for joining us today. So I won't introduce myself again. You all just saw me here very briefly. So my name is Cameron, and I just want to kick off this next session, which is going to be focusing on the telehealth journey. I have two others on this presentation with me today, John Henry and Dr. Pritam Ghosh, who is from SOC Telemed. I'll give John a chance to introduce himself here in a moment, and then I'll introduce Dr. Ghosh when we transition into more of the interview section of this presentation. So I wanted to give a chance just to highlight a couple of the programs. So as I mentioned before, I work with the Indiana Rural Health Association. I'm director of two HRSA-related grants that are focused specific to telehealth. The first being the Crossroads Partnership for Telehealth, where we work with around 8 to 9 rural hospitals to help implement and evaluate telebehavioral health and telestroke services. So really the purposes of these programs are to be able to provide implementation support for rural hospitals. So that includes an annual stipend to help cover any offset for equipment fees, licensing fees, if it can help with any staff expenses, to really be able to help with some of those startup costs, in the hopes that we would be able to evaluate those telehealth, or be able to evaluate and sustain those telehealth programs long term. And so one of the big components of that is also collecting that data, specifically for the purpose of being able to demonstrate an evidence base for telehealth. Now, when it comes to the Upper Midwest Telehealth Resource Center, we really serve as a telehealth resource center for the entire region. And so we work with the states of Indiana, Illinois, Michigan, and Ohio. And really we're meant to serve as a one-stop shop for all of your telehealth related questions. And so we provide individual technical assistance, connections with other programs, as well as any individual project assessments that you may be looking for. But we also have a variety of different educational opportunities that we provide. So we host a monthly webinar series. And we also make sure that we host events specific to telehealth policy and reimbursement. So this month, we actually had our State of the Region, where we covered some of the specific guidance when it comes to the regulations and policies specific to telehealth. We also host a bi-monthly podcast where you can come in and listen to anything specific to telehealth, health equity, and just the technology field in healthcare as a whole. And then lastly, we do provide individual training. So for organizations that may want specific trainings for their providers or administrative staff, we do host a variety of workshops that we provide for those organizations as well. I do want to mention, for those of you who are on the call that are located near South Bend, but all of us are in Indiana, we are hosting an annual conference. It will be September 13th through the 14th. That's specific to telehealth. For those of you who are involved in telehealth, perhaps you're attending the American Telehealth Association's conference coming up here in just a couple days in Boston. Really what we wanted to be able to do here at the Upper Midwest Telehealth Resource Center is to bring a telehealth conference a little bit closer to home. And so really that's what this is going to be focused on. The biggest things we're going to focus on are some of the, we're going to be focused on workforce and policy specifically throughout the conference. So if you haven't had a chance to attend in the past, or you have attended in the past, I just wanted to let you all know that exhibitor and attendee registration is live, and you're free to sign up on our website. And then the last thing here before I hand it off to John is for the Upper Midwest Telehealth Resource Center, we have multiple ways you can connect with us. So we have our website where we host a lot of different resources specific to telehealth services. We have our podcast, YouTube channel, and social media channels that we all cover any updates in the telehealth industry. And so with that, I'll go ahead and hand it off to John to talk about SOC Telemed.
Thanks, Cameron, and great to meet everyone today. Like Cameron said, my name is John Henry. I'm the VP of Client Services with SOC Telemed, and I've just looking at the attendee list real quick. I've worked with a few of you and over the past couple of years, and we're looking forward to presenting today and really just talking about telehealth and kind of all the spaces that it can fit in the hospital, with many of which you've seen, and maybe answer some questions. But SOC Telemed specifically, we're the simplest answer to that is we are a tech-enabled clinical services group. And so really our focus and kind of the genesis of everything we'll talk about today is trying to mimic the look and feel of in-person practice just via telemedicine. And so what does that look like? I heard a lot of the previous presentation, and I thought the end of that call was great, and they made some great points about the tech and why it's important, and good questions to ask. But Cam, if you'll go to the next slide. But overall, these are just kind of the areas we work, just for some reference and background. And we work both ambulatory and inpatient. And we really focus on partnering with hospitals to whatever size program that they need, on both inpatient and outpatient, where we can help partner, and if not, get them connected to the right resource. But I didn't want to spend a lot of time talking about us today as far as that goes. I think the panel discussion will be a lot more interesting with Dr. Ghosh and Cameron. And so if y'all want to kick that off, Cameron, you're more than welcome to.
All right, thank you, Tom. So as John mentioned, we wanted to spend some time just to be able to kind of have a discussion about just kind of a telehealth journey. We definitely wanted to be able to provide this kind of in a different format, maybe than what we could have done, but we really wanted to be able to utilize the expertise of Dr. Ghosh, who's had experience kind of on both sides of telemedicine, so providing the services as well as being on the administrative side as well. And so really kind of with that, I just want to give Dr. Ghosh just a chance to just introduce himself and tell us a little bit about how you got involved with Access Physicians to begin with.
And thank you. Good to be with you all. My name is Preetham Ghosh. I'm the service line chief for pulmonary critical care. I'm one of the co-founders from back in the day with Access Physicians in 2013. And Cam really got into telemedicine because myself, along with several of the other co-founders, we were moonlighting as fellows in a rural hospital in East Texas and covering this hospital 24 hours a day over the weekends. And then we would leave, and we were all critical care, in critical care fields. One was a cardiologist, Chris Gallagher, myself, and pulmonary critical care. And we would leave after our 24-hour shift, and the local docs would come back on and say, hey, what do we do with these patients you admitted over the weekend? And we realized that there was a need for subspecialty care in not just rural Texas, but rural America, because there is a dearth of new recruits and new graduates coming to these areas. And we realized that this is a great place to start a telemedicine platform.
Absolutely. And kind of with that, you got some of that initial exposure when you were a fellow. So there really must have been kind of a point even past that in your career where you realized telehealth could really benefit your practice. And so I know you're board certified in internal medicine, pulmonology, and critical care. But what were really some of the drivers that turned your practice to telemedicine?
This is 2013 when we started, and it was a concept at the time, right? And then when we actually launched the program, we started to realize the impact that telemedicine can have. We started to see sick patients not getting transferred out, families and patients being able to stay in the community, closing the loop of care with an outpatient clinic. We could see the immediate impact very quickly. And as we grew and progressed our practice, we realized the niche that we were filling at the time. And that has continued to be the story since that time, as we've grown and expanded.
And so as you've kind of grown, you said you started in 2013, and so you've been able to see growth, a ton of growth over the period of time in the field of telehealth and telemedicine. And so can you tell us a little bit about the types of patients that you typically treat?
Yeah, I would tell you from a critical care standpoint, and kind of overseeing some of the other programs as well, you really want to take care of patients that can avail of resources that are local, right? So, from a critical care standpoint, if we're needing services like nephrology for dialysis or cardiovascular thoracic surgery for, decortication of pleural effusions or CABG, right? If the local resources are there, then we're able to manage these patients virtually. I always talk about medicine being 90% intellectual and 10% procedure driven in the primary care fields, right? If you're a surgeon, you're 90% procedure driven. So really, as long as you have the resources from a hospital standpoint in terms of being able to do procedures, central lines, intubations, and I'm speaking to specifically for critical care, the intellectual part can be done whether you're bedside or 1,000 miles away. Because medicine is medicine. You're not reinventing the wheel. You're trying to practice standard of care medicine, whether bedside, in person, physically, or bedside, virtually.
That's a great point. And I think that, a lot of times some questions that individuals have when it comes to telehealth services is really how do you identify patients who are the most appropriate to receive that type of service?
Great question. So a lot of times ERs or primary care hospitalists are calling us to run patients by us before they get admitted. We all know the difficulties, and especially with COVID, we all know the difficulties of transferring patients to higher level care centers once they're admitted. So a lot of times we're discussing these patients up front when they present to the hospital to run the clinical case, to really know that we have the resources to take care of the patient. And if we don't, then we obviously are looking to transfer these patients to higher level care centers. If we don't have any options, we take care of them anyways, waiting for that transfer. But those discussions initially that take place between the hospitalist, the ER, and one of us is really important because we can coordinate care together, talk about the resources we have available, talk about the resources we're going to need down the line, and make that decision up front.
Yeah, so you talk about, being able to have some of those discussion pieces amongst all the staff that are kind of involved. And so there are any particular protocols that tend to help with making that decision of when a patient is most appropriate to engage in telehealth?
Yeah, I think the protocols really are based, again, on what we have available locally, right? We agree upon the fact that if a person comes in with a GI bleed, if we have GI available to scope, then we keep them. Sometimes the narrative is GI may not be available for 2 days. And then we say, well, this person needs to be urgently treated. We need to transfer. Or if they're not urgently needed for an intervention, we keep them. So again, the protocols really depend on these resources that we have available to us.
Yeah, that definitely makes sense. And, after you have identified some of these patients who are appropriate for telemedicine and kind of funnel them through that. One of the biggest concerns that can happen either from a provider or a patient side is, okay, now I'm receiving this telehealth service. How do I really ensure that I'm receiving or providing the same quality of care as if I was doing a service in question? In person. So kind of with that, that's kind of goes with the question of how do you really measure the quality of service when it comes to telemedicine?
Sure. So one of the things I always tell providers that we're recruiting for our service, for example, and the answer to your question is twofold. Number one, I always tell our providers who are coming on that you're really behind the 8 ball a little bit when you come on screen into a room, because patients always want a provider in person. So we want to make sure that the providers that we're hiring and recruiting have a screen presence, have the ability to engage, have the ability to really take care of the patient, sometimes in a more detailed fashion than when you're in person, when you're kind of blowing in and blowing out of rooms, as a lot of doctors do. We encourage high level of engagement, right? We also know from experience that if you're going to do telemedicine, if you're going to practice telemedicine well, you want to recruit people who have experience in-person doctoring. It's kind of like going to business school after 2 years of being in the company you're working at. You have to have that in-person experience to gain the insight, to hone your instincts, to know, I've seen this 1,000 times. I can do this 1,000 miles away as well as I can do it bedside physically, right? The other part is we want to always practice standard of care, and that includes metrics. And especially in the ICU, you have metrics, number of vent days, number of days on the ventilator, length of stay. And we, as an organization, and not to sell us, but just to talk about telemedicine itself, we engage with clients on a monthly basis and report these metrics so they know that what we're doing actually holds to a standard of care and meets the metrics of the hospital and the client needs to be satisfied.
So I think, kind of boiling down what you said there, it's really the standard of care, when it comes to telemedicine, there are the same expectations, if not maybe more, when it comes to ensuring that there's a certain quality of care that's being provided for that patient. In addition, I think it's interesting that you say, especially when you're talking about you're recruiting for different individuals to be able to provide these telemedicine services, that there needs to be a baseline of they've seen this multiple times in person to be able to make some of those higher level decision making when it comes to moving that to a virtual platform. Because I think that's an important distinction of you're not just taking people straight out of med school, driving them into virtual care environments and say, hope you can figure it out.
Absolutely. Absolutely. I think telemedicine, one of my mentors used to tell me that critical care and pulmonary medicine is an art. And I think all fields of medicine is an art. It's an art that you mature over time as you practice. Well, telemedicine is an art. It is not just dropping a screen into a hospital and saying, go. You have to know how to do it well. And as new hires and people coming on, they have to understand the art that goes behind taking care of someone virtually, maybe 1,000 miles away versus in person.
Yeah, and so when it comes to that, what are some key skills that a physician can, when you're looking for physicians who are providing telemedicine services, what are some of the key skills that you're really looking for?
Cam, honestly, the basic skills that we look for are the basic skills anyone looks for in a physician or a provider. Do you care about being detail oriented? Do you care to make sure that you are engaged in continuity of care? Do you care that you are closing the loop on both ends from the admission to the discharge, right? Those are basic principles that I think any good physician or physician extender or provider should have, right? But more importantly, I think for telemedicine, what really matters, and we have this term that we talk about, breaking through the screen. You've got to have a level of social engagement in order to engage with a person that is not in front of you, right? So we do look for screen presence as a next extra layer on top of the basic principles that guide physicians and extenders to be good providers, to be good stewards of medicine.
Yeah, and with that, you talked about really having a good screen presence, especially when it comes to telemedicine programs, really being able to educate patients on, setting expectations for the telemedicine visit, as well as educating them on technology. Do you have any advice on, how you can help kind of bridge some of those barriers when it comes to educating patients for telemedicine appointments?
I think the most important thing, Cam, is to come in and be honest about who you are and what you're doing. And I think it's very important to let the patient know that even though you're not there in person, that you're still going to take care of them the same way as if you were in person. You want them to feel comfortable that the care they're going to get is equal to me being there in person. And so that expectation is set pretty early. I always assure patients, and the nurses that I work with always laugh about the fact that I always sign off on my first encounter with, "We'll take care of this and we'll get it done," right? And that just lets the patient know that I'm there, I'm invested, I'm going to take care of them start to finish. And I'm also honest with them when I think that they might need something more than what we have to offer after that initial discussion with the ER and everybody else. I tell them, I said, look, if we find out in the next couple of days that there is something more you're going to need, I assure you we'll get you to where you need to be. In the meantime, we will take care of what we need to take care of now. That gives them the assurance that they're not just tied to the telemedicine platform. They know they have a provider who's looking 4 or 5 steps ahead and has a plan to take care of that if it were to occur.
It's a great point about really being very honest and transparent of, this is what we're able to provide through this telemedicine service. And if, this isn't meeting what you need, we will adjust to make sure that you're getting the appropriate care. That's a great point.
Yep.
And so for a lot of the audience, maybe this is the first time during the pandemic, might have been the first time that they had to implement a telehealth program. And maybe a lot of them are looking to see, how do you begin to look at sustaining a telehealth program long term? So from your experience, what is kind of an ideal setting for implementing a new telehealth care program?
Kim, I think it depends on the services you're trying to provide, right? I can tell you from a critical care standpoint, we have a sweet spot of engaging with clients for a long-term program where they have moderate level of acuity, sometimes high, but don't have a huge volume in their ICU. For example, if you're looking at a 25-bed ICU, you're looking at about a 200+ bed hospital. In order to do critical care, the 10% is procedures. And if you're having to engage providers on the ground for 10, 7, 6 procedures a day, you're eating into their time. That is not an ideal place to launch a virtual care program, right? You want to be able to practice critical care, ask providers to help you with procedures 2 or 3 times a day, but not eat into their practice time. So, as you can imagine, we've run and skinned our knees 1,000 times during this process, and John knows this really well. We have found what works and what doesn't work in terms of longevity. And longevity means from a virtual care platform, you're looking at moderate-sized hospitals, moderate-sized ICUs, small ICUs. You get to this threshold of 15, 16 beds, you start to realize you're going to have a higher acuity, higher volume of patients that need higher numbers of procedures. And that's where we say, okay, maybe this is where we engage with a physician extender and supervise care with them. We can cover those places at night where maybe you have 1 or 2 admissions and you can ask someone to do 1 or 2 procedures. But there is a sweet spot, and we are able to pivot and sort of launch different types of programs, whether it be hybrid or by ourselves. But it really depends on how engaged the providers are on the client end to help us do what we need to do from a procedural standpoint, right? So there is a sweet spot where you can cover a facility 24/7. There are sweet spots where we say we can cover at night. And then there are places that are outside those reaches where, honestly speaking, we don't engage with the virtual care platform. And we are very upfront with clients about that. You've got an ICU that's 24 beds, you need someone in person, right? And so I don't want to ever come across as someone who says we can do everything all the time, but we can do a lot of things really well a lot of the times.
Yeah, and I think with that too, you alluded to it a little bit of, kind of this integration of how do you integrate a completely remote team with a local team to make sure that your program's successful. So can you speak a little bit to that?
Absolutely. So we go through a 6 weeks to launch, where on a weekly basis, we are introducing ourselves, meeting with, working through workflows with executives and providers on the client end, right? We have what we call hearts and minds meetings, where I will talk to a hospitalist group that's on the ground, the anesthesia or surgery team that might be helping us, to really engage with them to make sure that we're all on the same page. So that is an intricate process that we've developed over time, knowing that, again, you can't just drop a screen in a cart in a hospital and expect it to go. You have to be able to establish relationships. And then more importantly, as you go through the program, maintain those relationships, right? It is important to communicate even more so in telemedicine with the providers on the ground, back and forth, talking to them about what we're doing, what we're seeing, what we need to do. And so again, it's an art that requires attention, and it's a plant that needs to be watered from the front end to the back end.
Yeah, that's a great point. Even something we've experienced with our Crossroads program when it comes to some of our telestroke services we've had some hospitals that have had some changes in the providers that are working there. And so some were coming in and didn't have a background in even having a telestroke service available at their organization. And so they were kind of reverting back to, their typical habits of where they were doing a phone consultation with a neurologist rather than doing utilizing the telestroke service. And so really making sure that, those boots on the ground are really well connected with some of those remote team members, really make sure that it's being utilized and make sure that, all of the individuals really know how to work well together, especially if they're not physically present in the same space.
Yeah, Cam, listen, communication is the cornerstone to good healthcare, right? And I think that communication extends not between providers, but everyone, right? The executives who want you there, the leadership who wants you there, the providers who are coordinating care with you. And this is something I tell, I still do rounds of the academic center here in Dallas, and I tell residents and fellows, you gotta be able to communicate. If you don't, things slip through the cracks, and people are just left not knowing what they're gonna do when you don't have that level of communication that's really necessary.
Yeah, really having someone at that site who is really a champion for the services, to your point, kind of really helps to facilitate a lot of those connections, especially on the front end, when things are new and, individuals aren't familiar with each other. I wanted to ask, with each telehealth program, we talked about, so communication can be a challenge. But what are some of the other challenges that a telehealth program can face, and how do organizations help to address those?
I think that one of the biggest challenges is, and it's not a challenge per se, it's something that we always talk about, is making sure that everybody's on the same page, coming to an agreement on workflows, making sure that whoever it is that's coordinating care with you understands who we are, right? I've had conversations after a launch 6 weeks in where I'm calling someone at 3 o'clock in the morning to help us with a procedure, and they are on the phone saying, "Now, who are you?" And then I tell them who I am, and then they say, "Well, I'm not really sure why you're calling me. You can do this procedure yourself." And I have to explain, well, I'm actually not there in person, right? So setting those expectations in terms of workflows with the team on the ground is probably the most important thing, at least with critical care, right? I think it's just as important for other platforms with other specialties, right? Whether it's cardiology, nephrology, ID. The people you're engaging with have to understand who you are, what you're doing, what your limitations are. And as long as everybody knows that, which is why we do these hearts and minds talks to introduce ourselves, as long as that happens, it can be a well-run program, but you have to have those expectations up front, and people have to know what you're doing and how you can help them.
Absolutely. No, that's a great point. Especially, workflow standpoint, that's something that we've experienced a lot too, to make sure that everyone is on the same page of this is the workflow, this is what, this is the specific patients that will be referred to the program, and really making sure that everyone understands that and really, follows that to the best they can. So as you started in 2013, so we talked about some of the challenges. What were some of the specific challenges that you faced whenever COVID first entered into the scene?
Cam, I don't think we have enough time to talk about all those challenges, but I will tell you the biggest challenge was to have hospitals who are not used to taking care of really sick patients, to have them able to take care of those patients now, because these patients had nowhere to go from a transfer standpoint. It was really cool to see the learning curve on the client end with nurses, RTs, in terms of their ability to pivot, adapt, and take care of these patients. I can tell you that I'll tell you a specific story. We are in this 8-bed ICU small hospital in sort of Western Texas, west of Dallas. So I consider everything west of Dallas as west. And you're talking about a sleepy hospital with eight beds in their ICU. Their average daily census is probably 2 or 3. Every now and then you'll get somebody with DKA, somebody comes with septic shock. And I remember distinctly rounding one day, and all 8 beds were occupied by patients on the ventilator, half of them proned. And I asked the nurse on the other end, I said, "How often have you proned a patient?" And she said, "First time, Dr. Ghosh, yesterday." We had a protocol in place, so they followed the protocol. We supervised the actual proning process. But it was really cool to see a hospital that had never seen anyone sicker than maybe a couple of days, 8 beds filled with prone ventilated patients who were paralyzed. To me, that was the day I realized that, you should never underestimate a hospital or its staff. They can always learn to do things at a higher acuity than they've been used to. But that also speaks to a level of supervision that's required from our end, right? It's really easy to walk into a big hospital where all the ICU nurses are trained to do everything and say, "Yeah, I want patients bed 2, bed 5, bed 6 prone," and you walk away. Well, you don't walk away in situations like this. You're bedside watching the proning process, making sure it's being done. And it's fun. It's fun to watch that steep learning curve and to see patients being taken care of that otherwise would have been in a bigger center.
Yeah, I feel like adaptability is a great way to summarize the past couple of years. And the amount of adaptability that healthcare professionals have had to work with, of just a constantly evolving landscape and multiple different facets. And so we've seen that in telehealth, where we've seen, variety of different changes when it comes to policy and reimbursement. There's a ton of healthcare professionals that now have been able to provide telehealth services during the public health emergency, that was just recently extended until July of this year. And we've seen a huge demand for the services. So there's been lots of recent data that's come out of, patients are desiring to be either in a virtual model of care or some sort of hybrid model of care, and providers are wanting to be able to provide some of those services. But can you speak to, some of your personal experience of, seeing the demand for telehealth increase, in 2013 to where it is?
I think, Cam, the appetite for telemedicine has increased exponentially in the last 3 years. COVID forced a lot of virtual care platforms and forced patients to be able to engage on a virtual care platform. The understanding, the acceptance of it has grown beyond measure in the last 3 years. 2013, when we started, the general public kind of didn't really know what telemedicine was. We'd roll a card in to a room and they'd kind of look at us skeptically and say, okay, I guess we're going to do this, kind of weird. But now you walk into rooms on a virtual platform and patients just know. They know that because they've been seeing their primary care providers for the past 2 years on a virtual platform on their laptop at home. So the acceptance, the understanding of how well telemedicine can really take care of you has grown. And so with that, the demand for it has grown. I think everybody understands, in 2013, when we were doing virtual critical care, even my colleagues at the academic center were kind of looking at me like, what, you're going to do what? And now these same colleagues are using virtual care platforms because they had to do that during COVID. So the understanding and the acceptance has led to that increased demand over the last 2 to 3 years.
So this is a little bit less concrete, but with that increased demand, what are some of your predictions of what telehealth will look like in the next, we'll say the next 5 to 10 years? So the one thing I want to emphasize to answer your question, Cam, is telemedicine will never replace in-person doctoring, okay? It has its role, and I feel that because we understand the reaches that it can have, I really feel that a lot of hospitals in the next 5 years will start implementing telemedicine when they don't have other options, right? And they will realize that the care that's being provided is the same, sometimes better. When I'm on shift, I can jump in and jump out of a patient's room 10 times a day. Whereas if I was in person and I had to round in the ICU during the day and be in clinic in the afternoon, I can't run back from clinic to the ICU 5 times. With telemedicine, you can, right? And everybody on the ground starts to realize, wow, you actually have an availability that sometimes exceeds what it would be if you were in person. So I do think that there's going to be a continued, I don't want to say exponential, but I think there's going to be a lot of growth in especially rural markets where leadership has been looking for years to fill an intensivist spot or a cardiology spot. And now they're going to reach out to organizations that can give the same care virtually and understand that the quality is the same. So I really anticipate a continued growth in a direct fashion for the next 5 years. Absolutely. And I think a lot of feedback that we've heard from organizations, in our region, in Indiana, Illinois, Ohio, and Michigan is, as they've been able to provide this level of care, it's really hard for them to envision of really doing anything different. And so they've kind of gotten a taste of it. Now about the pandemic, it might have taken longer to get there, to really be able to try out those services, get some of that patient feedback. We have the most patient feedback we've ever received for telemedicine services now, to really be able to see how it's impacting patient lives, how that service is ultimately either helping, especially what we've seen working in rural areas with telestroke services, of being able to provide a service that it wasn't present there perhaps without that telestroke service. to have that specialty service available is a huge benefit for the community, and for something like stroke where seconds matter, and being able to connect with a specialist can change someone's life. I mean, that's a huge benefit, and hopefully, as you said, we'll continue to see that trajectory where that will grow more and more in the future. And we're always keeping tabs on where things are from a policy and legislative standpoint. At least now, just for individuals on the call who maybe are following that and are looking at what are some of the recent changes. So as I mentioned, the public health emergency is lasting through July. And so a lot of those waivers that we've had throughout the pandemic, those are for sure going to last here for a few more months. But additionally, with the omnibus bill that was signed in the 2022 Consolidated Appropriations Act, we're going to have a 151-day extension for some of those COVID waivers to be able to continue to provide some of those services. There are some small nuances on what waivers specifically are included in that. However, that still brings us pretty much to the conclusion of 2022, where a lot of these telehealth waivers that we've seen are going to continue to be intact. And so, as you were saying, Dr. Ghosh, as we have even more time where maybe some of these particular providers, particular services that weren't reimbursed prior to the pandemic, and we've seen more of those services provided, perhaps we'll see a lot of those really positive policy and reimbursement changes whenever we have the newest version of the physician fee schedule for 2023. And Medicare made some specific stances when it comes to some of those waivers.
Yeah, I think you hit it on the head. A lot of regulations were lifted to allow for telehealth to be a part of regular care, and I think we're gonna continue to see that, because again, the acceptance of the quality is a big part of it. Because when you start to see, and you start to speak in sort of research terms, telehealth is non-inferior in many ways to regular in-person doctoring, right? That has been published and looked at in multiple journals. So as that data starts to become more commonplace, I think the regulatory commissions are going to start to realize that if it's non-inferior and in fact superior because you're having direct access more quickly, those regulatory commissions are going to continue to allow this platform to survive and to continue. I think allowing for reimbursements to occur on a telehealth platform is huge, and I think that will continue as well. At the end of the day, everybody's main concern is to make sure patients get taken care of. And if you're taking care of patients as well on a telehealth platform as you would be in person, and at times even better because of your availability, I can't imagine regulatory commissions starting to clamp back down, because this is, I think, a new age and a new world in how we practice medicine.
Absolutely. With that, because I want to leave a little bit of time to where the audience can ask you some questions, and me questions and John questions here towards the tail end. The policy landscape and the reimbursement landscape for telehealth is definitely a bright spot. We're seeing a lot of changes in that direction, and even seeing some permanent provisions, telebehavioral health being one of the biggest example of seeing permanent provisions of geographic restrictions being lifted, some reimbursement for audio only codes that will remain permanent after the public health emergency. But for organizations who are maybe looking to gain buy-in or adopt, telehealth programs in their organization, can you give any advice on how to grow a vision for telehealth among leadership and staff?
I think it all begins with honest conversations about what telemedicine can provide and trying to meet the needs of that particular hospital or clinic, whatever it might be. I think introductory calls where you really talk through the process to educate leadership and important people on the client end on how and what we can do, those are the most important for growth, because irrespective of the fact that telemedicine has become a part of our daily lives in terms of healthcare, there's still a lot of questions, and different people clients, hospitals, clinics have different needs and different resources. To really have those upfront, honest conversations about what we can provide, to do that Q&A. I mean, I would tell you, and John knows this, half of our initial sales calls are just Q&As, where it's leadership asking us, telling us what they need, us telling them what we can do, coming to a common ground and saying, yes, this is a viable option. And there are calls where we realize this is not a viable option, but that, to have the interest is the first step. To then learn about what it can do for you is the next step, right? And then there is the buy-in from providers on the ground who are used to a certain way of doing medicine. I mean, you're dealing with doctors who are very steadfast in the way they do things, and someone who's been practicing medicine for 30 years is a bit skeptical about what this new age technology platform can do. That is a process that continues even beyond just those initial calls, because a lot of times, and I'm the same way, if someone tries to sell me something, I want to see it at work, right? I want to see what it can do. You know, you don't ever go in to a dealership and buy a car without driving it first. So in order to answer those questions up front, honestly, to come to a common meeting ground, and then to launch it and continue that buy-in process with the care that you're providing is very important.
Yeah, and so really being able to just to kind of condense, really being able to understand what are some of the gaps and how does telehealth kind of enter into those, and really kind of using those 2 points to really, make kind of a business case to the providers, leadership, and staff of, this is where this telehealth program would make the most sense for us. It might be a very specific specialty, it might be multiple, but kind of whatever you find in kind of that initial fact finding will really help guide you on what makes sense for you.
Absolutely. And I also encourage leadership and executives to talk to their friends in the industry who are already using telemedicine to see what their experience has been, right? A lot of filling in the gaps can occur just with their honest conversations with their own colleagues, right? And so that is an important step, I feel, to moving forward with something like this. John knows this really well. We get referrals because someone has spoken to someone who's a friend who's an executive at another hospital down the road, and they say, hey, we're using it. What is your experience? And when they hear about the experience, that's when their interest peaks even more. So I do encourage those open conversations with other colleagues that are already using telemedicine to really see what it can do for you.
Absolutely, yes. So I know we're getting pretty close here on time, so I'm going to go ahead and pause here. And so for any individuals that are listening today, if you have any particular questions for John, Dr. Ghosh, or I, feel free to utilize the Q&A or the chat function. And I'll just give us a couple minutes here to see if anyone has any particular questions for us.
Cam, this is Becky. Kind of a comment and a question is, totally agree that telehealth is an art, and hit the nail on the head with that particular comment, but just wondered, do you provide any particular sessions or trainings for individuals to be a little more proficient in conducting telehealth? Because I've been a recipient even myself, and I loved it, especially in this busy world, and particularly with follow-up visits where you just have a touch point, but just wondered if there were any particular trainings around that.
Great question, Becky. So as a matter of fact, and John can speak to this as well, we have created what's called TeleU. I know it's a little catchy and glitchy, but it's called TeleU. We have a program where we take providers through a training session, multiple training sessions, to become more proficient, right? And it's something that we have talked about for a long time, this breaking through the screen concept in terms of making sure that providers are engaged at a level that patients require. And so, yes, we do provide that training for providers who are starting off to get them more proficient with follow-up training sessions and whatnot.
I'll say too, from the Upper Midwest Telehealth Resource Center, we have done several workshops with organizations, and we've done it more. We've kind of broken into two tracks. Sometimes we're doing a training specific to administrative staff. So, how do you make a business case for telehealth? How do you market your telehealth program? Some of those kind of more administrative type of topics. And we'll do some trainings with providers directly on, what is some website etiquette, how do you develop a telehealth workflow? However, I'm not a clinician, so I can't provide certain levels of trainings there that maybe Dr. Ghosh can, but we do provide and offer those workshops for organizations that are interested if they want that type of training for their providers or for their leadership staff.
Thank you. Good to know. Good to know. I have not received any additional questions directed toward me. Dawn, had you received any?
No, I haven't. Don't see any on the chat or Q&A.
All right, so I think with that, so please feel free if you have any additional questions about SOC Telemed, the Upper Midwest Telehealth Resource Center, or anything specific to telehealth, please feel free to reach out to one of us that were on this presentation today. But want to just appreciate and thank all of you for attending, and thank you, John and Dr. Ghosh, for being on this session with me. And with that, I will go ahead and hand it back over to Becky.
Thanks, guys. Great meeting you all.
Thank you. And Don Gettinger is going to wrap up our session for today.
Thank you, Becky. I want to say what a great conference it's been. I think we've had some great speakers. I want to thank all of our speakers today, especially the last ones. And then our partners, the Indiana Department of Health, the Indiana Rural Health Association, the Indiana Patient Safety Center, and for myself at Q-Source, thank you all for attending. I do want to give our partners an opportunity to share any announcements or anything that they need to just share before we go. And I know that we are going to have a short poll here at the end as well, just to give us some feedback as well. So
This is Becky, and I tried to share a link to the evaluation in the chat, but it's not popping in as a link. I don't know if people can click on particularly the second box in the chat, but if not, I will send it out with the recording, but we do need your evaluations.
the evaluations are critical to make sure that we can share back with our speakers so that they know what they can do better, but also so that we know how we can better serve you at these future events. So I wanted to open it up. Do any of our partners have anything, announcements that they do need to share before we go?
I will say that we will be sharing the slide deck from the beginning of the program today with the different sessions and meetings and announcements. And definitely please submit the Critical Access Hospital Awards. There's been a lot of wonderful things that have gone on across the state, some great patient stories that we've been hearing. So please submit those award nominations, and also the STAR Award that's provided by the National Rural Health Association or for the state offices of rural health.
Karen, Carolyn, or Tina, do you have anything you need to share?
Well, on behalf of Indiana Rural Health Association, if you have not registered for the IRHA annual conference in June, please do so now. And the room block will be closing mid-May. So if you are registered, make sure you have called the hotel or have gone on the passkey link so that you can register for the hotel very, very soon. It's filling up quickly. Thank you.
Just want to say thank you to everyone for joining today.